Okay, let's start. Hi, everyone. Welcome to Imaging Study. Today, we are going to talk about some ultrasound cases, and these cases are from my regular practice. Walaikum assalam and assalamu alaikum. We actually try to arrange this type of sessions every week on every Friday. Due to workload or some busy schedule, we miss sometimes, but we will try always, or we tried always to make it a regular. So anyway, thank you for joining us. If you are new to our program, I'm Dr. Mahin from Bangladesh, and we will try to share 5 cases today. And hopefully this will be a long session because 1 or 2 cases are a little bit bigger than a usual one. So try to have some patience. And if you're new to our program, we have an ultrasound channel that is known as Imaging Study. We try to post different cases here, and nowadays we try to share our these live sessions recorded version in our YouTube channel. So if you have missed our previous sessions, just go there and you will get all the previous sessions that are already been uploaded. So without any further ado, let's jump into our today's first case. So this is a 45-year-old female patient who came with amenorrhea. No, the patient is not pregnant. And she complained about the lower abdominal pain. So there was a history of amenorrhea, I think, for 7 or 9 months, something like that. I forgot. So let's see what we have got on ultrasound. So here is the view of the pelvic region. You can see the longitudinal section of the uterus. So let me freeze the image. On first impression, what I thought first, it should be an adnexal structure. You know, the patient is 45-year-old. She had got some, I think, 2 babies. So uh, the first thing that came into my mind is that the lesion should be adnexal, but no, the adnexal was quite normal. So I'll show you. So here you can see the view of the uterus in longitudinal and transverse sections. Now, uh, what you can see, if it was an adnexal lesion, you would just go with the cyst and you will try to describe the nature of cyst, type of cyst, whatever. But this thing is uterus and the patient is 45 years old. So or what it can be. So if you look at the adnexa, let me just remove the confusion. Both ovaries were quite normal. Ignore the measurement techniques or the measurements. Both ovaries were normal. So the structure you're looking at is not an adnexal structure, rather this is the uterus in longitudinal section. Now, if you look at the internal structure, compare the echogenicity of the internal area with the urinary bladder, you can see the bladder is anechoic. So this area is not completely anechoic, rather it is relatively hypoechoic with fine low-level internal echoes. You can see some calcified area inside also. So what it can be, this is actually the blood products or menstrual blood within the uterine cavity. If it was an adnexal lesion, you would easily go for the endometrioma, but it is within the uterine cavity, and now we are going to call it a hematometra. Okay, so now if you look at the myometrium, the myometrium is very thin. That is a very important point because this lesion is causing disturbance to the myometrium. Now, if you look at the cervix, the cervical canal looks quite normal. The only thing that you can see is the dilatation of the endometrial cavity at the level of the body and fundus of the uterus. So the uterine cervix is quite normal. So there should be some obstruction going on at this level, that is the level of internal os or the lower uterine cavity. So what may be the cause? It may be the post-infective state. There may be some stenosis happened at that part. So it can happen. Okay. So the clinician will go further for the management of this case. So this is a case of hematometra. Let's look at the transverse section. You can see the uterus has already got slightly enlarged in size and with a thinning of the myometrium. So this is the hematometra. You see another view, and these fine low-level internal echoes represent the menstrual blood. Okay, here's another longitudinal section, and now you can see this whole of the hematometra in longitudinal section of the uterus, and the cervix is still quite intact without any endometrial collection at that part. Okay, so let's look at the vaginal canal here also. The vagina is also completely normal. So there is no collection at that part to say hematocolpos. So only thing that is happening here is the menstrual blood collection within the uterine cavity with myometrial thinning. So here's the picture on longitudinal and transverse section. You can see the measurement of the uterus. And now the uterus is slightly bulky. If it is more than 4.5 centimeter in anteroposterior diameter in a multiparous patient, we go for bulky in our center. So so there is a thinning of myometrium, which should be clinically important because this patient needs some management to preserve the normal myometrium already, which has got thin. So this is a case of bulky uterus with hematometra and significant myometrial thinning. Okay, before jumping into the case number 2, don't forget to share your location from where you are getting connected to us and watching this session. So this is quite fun to see your comments in the YouTube video and also the Facebook video, because many of you are watching this content from very far away from my country, actually. So it's quite interesting and it's fun. So let's jump into the case number 2. This is a 16-year-old male patient, and he came with a left thigh painful swelling. There is a history of sports injury, like some ball or football or cricket ball, which actually just got attacked to his thigh, and there was a pain and swelling, which is quite common. So the clinician sent us for evaluating the area. Let's see what we have got on ultrasound. So here's the picture of the longitudinal section of the antero aspect of the thigh. You can see the thigh muscles, and you can also see some abnormal structure here. These are not fragmented bones. The femur was quite normal. This is the femur. Now this is anterior to the femur. Okay, so you see the whole some echogenic structures casting post-acoustic shadows. So this might be some calcified areas. I took the history. The patient gave history of the swelling or the history of sports injury around 1 month back. So there is a long history. Okay. So now if you see the area, there is some heterogeneous area here also within the muscle. This muscle is the vastus intermedius, which is the anterior muscle here, very deep muscle anterior on the anterior side of the thigh. So let's jump into the transverse section to evaluate a little more. So here is the vastus intermedius area, which is showing intramuscular collection. And you can see surrounding edematous area. There is a huge collection, but the problem is that we have seen the calcified area, but here on transverse section, you can see there is not only calcifications, but also some anechoic parts. And if you go a little further, you can see these are the edema here, and just go a little further. Now you can see the collection appearance has got changed. So this is hypoechoic. So this one is hypoechoic. You can see some anechoic components, and you can see some calcified areas. So it indicates that this intramuscular hematoma, this lesion is a hematoma, obviously, has different ages. So we usually see the hematoma as echogenic in early stage, then it turns into hypoechoic, then anechoic, then it may get calcified. So you can see calcification, anechoic areas, and also some hypoechoic areas. So this is actually a hematoma of variable ages. So, okay, so the area where I'm scanning right now is on this part. This is the right limb. I'm going for the left one, actually. So this is the part where the lesion is happening. So this is the vastus intermedius. So the lateral one here and medial one here. So this is the vastus intermedius where you are seeing the lesion. So let's jump into again. This is the femur, and now you can see the start of the lesion with variable echogenicity. Let me freeze the image a little bit. You see some anechoic portions, some calcifications, and some heterogeneously hypoechoic areas. So there is a big chunk of hematoma over here. So the huge hematoma in the vastus intermedius actually. So this is the hematoma. That is an intramuscular hematoma. You see, this is a very long. So if you put the transducer transversely, now you can see the lesion again. As it's a long lesion, we can easily make a panoramic shot, which will be good, I think. So let's jump into the last video, and now you can see this hematoma here in a different coloring setting. So to just make your eyes not getting fatigued, I just change colors a lot of time. So this is just the hematoma. Okay, so here is the panoramic shot for you. You can see the anterabdominal, the thigh muscles, thigh muscles here, and the deeper aspect, which is the location for the vastus intermedius. Now you can see a whole hematoma over here, and you can see the calcifications, which is obviously indicating some very chronic appearance. So it's not a good technique to measure this hematoma with ultrasound, but approximately it's around 12 centimeter long. So it's not a very small one. So if you go for MRI, you can just make it a very good measurement, obviously, than hematoma, and then ultrasound, sorry. Okay, so here's the color Doppler. Now we put the color Doppler to see surrounding vascularity, and obviously this area should not show this amount of vascularity. Now you can see, yeah, very good amount of vascularity in the surrounding soft tissue. You have seen edema that indicates obviously there is an inflammatory process going on in the surrounding area. So this is the surrounding inflammatory changes. So this was a intramuscular hematoma of variable age involving the right. Oh, sorry, I was thinking of this one was the left one. So I made the mistake, I think. So it was the right vastus intermedius because I have copied this one from my own report. So I made the mistake. So don't make that mistake. So this was a right vastus intermedius muscle hematoma. Okay, this was right one. So I made the mistake. Okay, so let's jump into the case number 3. Okay, so this one will be the biggest one. If you follow me on Facebook, or if you have seen my post yesterday, I posted a case report, just the ultrasound report of a patient. So let's discuss about that patient. If you have missed, this patient took around 1 hour to scan and around 1 hour to complete the report. Actually, the patient took 2 hours from my life to solve all of these things. And I posted it on my Facebook profile yesterday that I am having a very big time-consuming patient. And this was the second highest time capturing patient yesterday. When I posted on Facebook, nobody actually asked me about which one was the highest time taking patient yesterday. That's the sad thing. Okay, so this one is the second time taking patient. Okay, I will show you the highest time taking patient on next session, hopefully. Okay, let's jump into this case. This will be a bigger one, so just have a cool brain and let's start. This is a 65-year-old male patient who came with the neck, abdominal, and scrotal swelling. So he was sent for 3 scans and the neck ultrasound, abdominal ultrasound. We do the whole abdominal ultrasound. That means the upper abdomen and the pelvic organs all are included here. It differs from country to country, so I'm just trying to describe. And was sent for the inguinal scrotal ultrasound also. So 3 ultrasound, okay. I asked the patient, what is your problem? Because he came with only just the investigation slip where it was written 3 ultrasound names. That's all. No history, nothing. So he didn't bring actually the whole papers, and it is quite common in my country. I don't know about others, but it's very common. So I would usually love to send the patient to come back again with all the papers, but this patient was not of that quality because he came from far distance from my center. And I think he actually needs some evaluation here. So anyway, I started asking the patient, what's your problem? Patient say that I only have the problem about hernia. So I need to solve the hernia. Okay, that's it. Let's jump into the case. So I will start with the neck now because I started with the neck in the actual patient. So I can describe it sequentially. So this is the picture of the not the midline. Okay, so this is quite on the um, right side, sorry, left side. This is quite on the left side. I put the transducer at this point, not at the middle part, on the slightly on the left. So you can see the trachea here. This is not midline, okay? So because the trachea was deviated in this patient, I will show you the picture. So here you can see the trachea. This is the isthmus, and this is the left lobe. You can see a cystic nodule here. And this one is the right lobe, which is hugely enlarged because of this big nodule, which I want to describe right now. You can see this is the common carotid artery over here on the left side. You can't see the right one because it has already got some pressure over that. Okay, so here's the measurement. You can see the isthmus is quite normal. The left thyroid lobe, it is also normal. Even you can say that this one is quite smaller. And you can see multiple nodules here. We will try to see all of them. So let's look at the left lobe nodules first. You can see one cystic nodule, which is completely normal. You can see a mixed one here, some solid component over there. We put Doppler because we always want to see the vascularity of the solid part, and this part actually showed some vascularity. Okay, ignore that. Now look at this one. This is the notorious one. You can see a hypoechoic nodule here, and it is solid one, and you see the margins are not quite well defined. A solid nodule, and now you can see some tiny echogenic area over here. We need to see it carefully. This is the let me just stop. It's quite jumping right now. Yeah, I can see that on the live session here because I'm also watching the live session. So anyway, let's jump into this one. Let me just describe again. So this one is the cystic one. This one is the mixed one. We have used color Doppler. We saw that the solid component, this tiny solid component of this mixed one also showed some vascularity. Okay, so my network is quite disturbing here, I think. Anyway, let's jump into this hypoechoic one. This one is quite irregular. You can see some tiny bits of calcification, that is the punctate echogenic calcification or punctate calcification over here, which is very notorious finding. Whenever you see a hypoechoic solid nodule with punctate calcification, it goes for the TIRADS 5. Okay, so just check the TIRADS scoring system. It will be TIRADS 5. So this should be the papillary cell. But okay, so let's look at the area. You can see this is quite irregular, and this is the echogenic foci. Now, sometimes any connection won't because it is a millimeter. So we put some Doppler. You can see good amount of vascularity, but be careful. You see this one? This is which is coming from those tiny findings that we can see in this yes nodule. So we don't love. So this is a very suspicious to show you. Okay, so this one is the punctate calcification. I think I have the another picture. No, I don't have. So let's see this one, this tiny structure, this tiny. Okay, now sometimes it makes some, sometimes with your machine, I'm using the musculoskeletal setup because this setup gives me very good vascularity appearance in my machine of this one. I don't want to just um, make a description of this machine because they're not sponsoring this video. Okay, so anyway, let's look at the color Doppler finding, and now you can see this punctate calcific area is casting some comet tail ring down. Sorry, the color comet tail or twinkling artifact. This one is the color comet tail or twinkling artifact. Okay, you can see here obviously. Now, let's look at the right one. Now, you see, this is the right area, and it has a big chunk of mass over here, which is pushing the trachea to the loser at the midline. You won't see any trachea. It is completely deviated this lesion. So it's a big one. Approximately it's more than 6.5 centimeters, so it's a big one. Now you see this is a heterogeneous nodule, even having some cystic spaces. So if you look carefully, you can see the marginal calcification is also present. Marginal calcification takes marks on the Child's scoring, so you have to describe that. And there are some tiny calcific foci here also, which is another notorious finding for this one. This is almost an isoechoic to hyperechoic nodule, and it's a solid one. So the patient went through the FNAC and biopsy from this nodule 2 times, and he said that yeah, 2 times the report was normal. There was no malignancy found here, which was quite interesting because it should not be. Okay, so why it should not be? It can be. So as this is a big lesion, there should be some confusion, obviously, but you have to search the surrounding region. Okay, anyway, let's see what we have got again in this patient. So we put some Doppler. You can see a very good amount of vascularity within this thyroid nodule. Um, you see the cystic spaces, they are now filled with blood. Now, when you see FNC history, you have to be a little bit careful. I don't know why my net connection is quite jumping. That's very sad because this is a big case and I don't want my network to get jumped. So let's over right thyroid gland, and it is almost occupying the right lobe. So we are not happy with this lesion. Now let's put some Doppler and see the lesion. You see a very good amount of vascularity over the lesion. But when we try to search for the abnormalities at the surrounding areas, we found something else. Let's see here. When we went to the lateral side, you see the carotid vessels, carotid artery and jugular veins are quite displaced. But you see some cystic spaces here. Now, you know, in this patient, I am just focusing on the papillary cell carcinoma. I'm trying to make it a papillary cell carcinoma because I have seen features of papillary cell carcinoma on the left lobe. So I'm just trying to be a little bit careful. But you see these cystic spaces, I want to make them the cystic lymph nodes or something like that. But you can see some flows within. That took my attention. Why there is flow within these cystic spaces? Are there some vessels? Let's put some Doppler. You can see a very good aliasing over here with a very good amount of vascularity. So now I have to be a little bit careful. Let's see the pulse wave Doppler of these vessels. Now, I took sample from multiple sites. I'm not showing you all those waves, but you can see this is the arterial flow. This is from the thyroid arteries because the wave pattern is of thyroid arteries, very high vascularity of more than 80 centimeter per second. Yeah, it may happen because this is a very big amount of nodule. But if you look at the vein is trying to make an arterialization of wave. So you see there's some pulsatile, a very good amount of, I'm not showing you all those venous wave pictures, but they all show the feature of arterialization, which took my attention because when you see a very big amount of, a large amount of a large sized nodule with a very good vascularity and some engorged veins within or adjacent to that part, showing you the very high arterial flow and the arterialization of the venous flow, it indicates there is an arteriovenous malformation going on. Why this arteriovenous malformation happened? That is actually arteriovenous fistula or shunt formation. Why it happened? The causes may be different, but usually two things we actually focus. The number one is the multiple time biopsy, which actually can cause this type of situation. Of arteriovenous communication may happen. And the next one is the large sized mass, which also has got some necrosis inside, and that may turn into a communication between the artery and vein. So that may also happen. So this patient is having an arteriovenous shunt inside, and it is a very important feature we see in malignant cases. So this is an arteriovenous malformation happened over there. Okay, so let's look at the lymph nodes. We have multiple things to see. And you can see this is the left supraclavicular lymph node. Just look at the appearance because I will show you same appearance a little bit later again. Uh, this is an enlarged, or no, not enlarged, it is a prominent lymph node. The short axis is not more than 1 centimeter, but you can see the complete loss of normal ecotexture. You can't see the ecogenic hilar fat over here. So the texture is completely obliterated. It is hypoechoic. Okay, we'll see these lymph nodes a lot today. So let's look at other parts. This is the right side. Now on right side, you can see some cystic lymph nodes. Whenever you see cystic lymph nodes in the neck, ignore the lymph node, look for the papillary cell carcinoma. Is a very important feature of the metastasis of papillary cell carcinoma, which are cystic appearance. So if you see the cystic lymph nodes, you go for papillary cell carcinoma. So we can see here cystic lymph nodes. So I'm very careful to make some papillary cell carcinoma in this patient. Okay, so let's see some lymph nodes. All are cystic appearance. We have shown you some. This one is not the cystic appearance. This one looks like the left supraclavicular lymph node. Okay, so there are multiple types of lymph nodes over here, I think. So some cystic spaces you can see here also. Okay, let's look at the surrounding area. So these are the cystic lymph nodes, but let me freeze the image a little bit. So these are actually the lymph nodes. And if you go here, just look at this one. This is not the lymph node. This is something else that we have put some Doppler over there. And we saw that these were the arteriovenous abnormality that we have described a little bit earlier. So yeah, now what do you want to say about this case? So we can say that there are multinodular goiter. We have seen different types of lymph nodes. Some metastatic things are going on, and you are focusing on this large nodule only, but the left lobe has a notorious nodule which actually covers the thyroid 5 lesion. So you have to be careful about that one also. So we took always a biopsy from the right one because this one is the biggest one, but the small notorious one may be found on the left one. Okay, so yeah, what about the left supraclavicular lymph node? Because that has got some different changes. If it was the papillary cell carcinoma metastasis, then it would show you cystic appearance, but it is quite different. So now let's look at the abdomen to make an answer of that question. So here's the picture of the abdomen. We're starting with the midline at the level of pancreas. Now you can see this is the pancreas. It looks quite normal, but surrounding fats are quite thickened. So something is going on there. And you can see multiple areas, hypoechoic areas over here. These are actually the lymph nodes. So get ready for adventure of abdominal lymphadenopathy. So this one is the aorta, this is the inferior vena cava, and all others are the lymph nodes. Not this one is the portal vein. Okay, so let's look at the surrounding area. This is the peripancreatic region or hilar region, para-aortic region. All are showing a huge amount of lymphadenopathy. Can you remember the left supraclavicular lymph node? Let me show you again. I think this one. You see the texture of this lymph node. Now let's look at the abdominal ones. Let me just open it. You see the texture is quite similar. It's hypoechoic, some reticulation-like internal appearance, and all these are same. That means they are all of similar type. Now what it can be? Okay, let's look at more pictures. So all are the large lymph nodes here throughout the upper abdomen. You can see outside the liver. Even you may get confused about, oh, this might be a hepatocellular carcinoma. No, all are same. They're all outside the liver. You can also see some collection here and there, some peritoneal collection, which are actually the feature of ascites. So, okay, let's look at here. So you can see, yeah, this is not the liver lesion. This is actually the lymph node, enlarged lymph nodes. So some hypoechoic, huge size lymph nodes all over the upper abdomen. So there's a huge lymphadenopathy, peripancreatic region, and the para-aortic. So yeah, this type of lymph nodes, when we see this type of hypoechoic lymph nodes all over the abdomen, we go for the lymphoma. That is our first priority. But is there two malignancies in this patient? Like we have seen the thyroid malignancies. Whenever you see cystic lymph node enlargement, you should be very confident because that is due to the papillary cell carcinoma metastasis. But this one is not related to that papillary cell carcinoma. It won't cause you this type of massive lymphadenopathy. So the patient is having another abnormality, I think. So to confirm it, we went for the flow, the pulse wave Doppler flow from the lymph node hilar artery. Now I have taken sample, I think 4 or 5 times. All the times the resistive index of the hilar artery was around 0.78, 0.79, at that range. So whenever you see the hilar artery is showing you the resistive index more than 0.7, it is due to neoplasm. Now we have got two differentials. Is it lymphoma or it is metastasis? In case of metastasis due to hilar arterial compression, it is usually more than 0.8. The resistive index. And if it is lymphoma, it's usually in between 0.7 and 0.8. So this is, I took 4 or 5 times from different lymph nodes and all are showing 0.78, 0.79. Yeah, you may say that 0.79 and 0.8 is quite same or may cause confusion. Yeah, we won't say that this is actually the lymphoma with only the ultrasound, but yeah, lymphoma is very important finding, and always remember that in case of lymphoma, you usually will get 0.7 to 0.8 resistive index. Okay, so just approve here. Okay, ignore that. Let's not ignore that. So let's look at other views. The liver was enlarged. You can see the kidney is quite echogenic. Liver is 18.1 centimeter. There is no fatty change here. We try to search for any tiny lesions within the liver, even with high frequency transducer, there was no internal lesions. Now, if you look at the kidney, it is echogenic. You can see multiple tiny cortical cysts over here. If you look at the other features, we have seen that the portal vein doesn't look quite normal. The kidney is echogenic. The portal vein looks quite dilated. You can also see some ascitic fluid at the hepatorenal pouch here. Okay, so we took the diameter of the portal vein. It's around 18 millimeter, but the velocity is quite normal. which may indicate that the liver is in increased demand of blood for some reason. So there is something abnormality of metabolism is going on here. So let's look at other features. You can see some ascitic fluid here, and you can see the gallbladder wall is thickened with some echogenic sludge inside. Why the gallbladder wall is thickened? It is related to the hypoalbuminemia. It is related to the ascites actually. So here's the picture of other lymph nodes. You can see I put the transducer at the midline at the around the umbilical region, and there are a huge amount of para-aortic lymphadenopathy. You can see similar type of lymph nodes in the right and left iliac fossa also. So the prostate was quite normal. We looked for any prostatic enlargement or suspected prostatic lesion. Nothing happened. Why this patient came to me with no papers actually. So anyway, let's look at the spleen. We have to look for something else in the spleen. There are some splenic hilar lymphadenopathy here also. The left kidney is also slightly echogenic, which may be reactionary or which may be obviously present in this type of situation. So there are multiple cortical cysts here also in the left kidney. So let's look at the spleen. You can see you're suspecting lymphoma. You have to look at the spleen carefully, and obviously you should use high frequency. So here you can see some hilar lymphadenopathy. Ignore that. We want to use high frequency. What you are expecting to see in high frequency? Let's see. Here's the picture. You see these tiny cystic spaces or hypoechoic spaces within the spleen on high frequency. You can't see it with the regular frequency. You need to use the high frequency. So these are actually the splenic infiltration. Okay, so whenever you see this type of tiny spaces throughout the spleen, this is diffuse infiltration. It is commonly seen in lymphoma and leukemia. Okay, so in this case, we want to go for the lymphoma, obviously. So here you can see this is the splenic infiltration. Okay, so always try to use a high frequency whenever you are suspecting something in the spleen. So these are the features of splenic infiltration. Okay, is it okay? No, it's not okay. We search for the umbilicus actually. We actually search all over the abdomen. So in the umbilicus, there was a hernia at that point. Unfortunately, I just pushed it and it went down. Only the fat content was present in the hernial sac. So I just compressed a little bit. It's a tiny small hernia over the umbilical region because I saw a bulging over there. Just put the probe and I can see that. So sorry. So there is a small hernia over here through which only the fat in this time is coming out to the hernial sac. Okay, so patient didn't talk about this hernia actually. So this is the last abdominal picture. So on a high frequency, you can see so many lymph nodes all over the abdomen. So we want to go for the lymphadenopathy due to lymphoma in such case. So none of these are showing you cystic appearance. Okay, let's look at the scrotum in this patient. So why not? Okay, so this is the feature image of testes. Yeah, both are actually slightly small because of age, I think, because the vascularity was quite okay in visualization. So the right one shows a slight hydrocele, but there was a huge swelling in the right hemiscrotum. So let's see what it was. If you put a little bit lateral or upwards, you can see a huge amount of fluid within the right hemiscrotal sac. But this is not the fluid within the tunica vaginalis. So this is separated fluid collection. And when we checked it a little bit, this is actually a big hernial sac containing a huge amount of fluid. Patient is having ascites, so all the fluids are coming down, I think. Okay, so you can see some intestinal loops are entering into the scrotum. This is the area of superficial inguinal ring, and this is the scrotal cavity is showing a hernia, a large hernial sac. So patient is actually complaining about this one because we always take care of our testes, not about our abdomen. So this one is the hernial orifice, and you can see ball loops are coming out into the inguinal canal. So it's around 2.3 centimeter transversely. And yeah, this is a right inguinal indirect hernia. So this is the tunica vaginalis layer fluid collection, and this is the actual hydrocele, what we call. Okay, so on the left side, patient didn't complain about the left side. Now on the left side, I saw this one. So there's another hernia on the left side. So I was very tired. Just after doing the abdomen and the neck, patient had to check the post-residual volume of the urine. So I sent the patient to toilet and took a cup of tea because I know I am going to have something abnormal in the scrotum also. So this is the hernia on the left side, which is also an indirect hernia. You can see the bowel loop and fluid. In this case, the fluid is very significant amount because the patient is having ascites, So the as a dependent part, the sacs are having some fluid there. So it's a big one, but a patient is not very much complaining about this one. Okay, the patient had some varicocele also on the left side. You can see some dilated vessels, and on Valsalva, they got engorged with a very good amount of reflux. So we took some measurements from different parts. If you follow this grading is from the Sertasi classification. So if you follow the Sertasi classification or you search it down on the Google, you can just get them. So on cum respiration, it was dilated more than 3 millimeter. And in supine position, we got the Valsalva. We did the Valsalva and saw the reflux. So this is grade 4 varicocele. Okay, and on the right side, there was also grade 4 varicocele. Okay, so on both sides, patient was having some varicocele. Okay, so varicocele has got 5 gradings on Sertesi classification on a very easy technique. If you follow the techniques and compare what actually urologists do in such cases, in grade 1, it is good to have a standing position to see the varicocele. It's easy to see the reflux, but we can also do it on the supine position. If we have confusion, we just turn the patient standing up. So in grade 1, the veins are less than 2 millimeter dilated, and we see the reflux at the cord level. And if it is grade 2 and grade 3, the veins are usually more than 2 millimeter in diameter in cum respiration. And for grade 2, you will see the reflux and dilatation in this prominent appearance at the upper pole. For the grade 3, you will see at lower pole. For grade 4 and 5, the veins should be dilated more than 3 millimeter. For grade 4, you will see the reflux with Valsalva, and grade 5, you will see the reflux without any Valsalva in cum respiration. That is the principle. In grade 5, it is obvious to have the atrophy of the testis. So that is the technique, but you can just go for the Sertesi classification and see the details there. Okay, so that's all for this case. Okay, so it took 1 hour actually to solve all the things, search for all the things. So this is actually the list of the findings. Let me show you the report, because ignore any mistakes I've done because I haven't checked that. So yeah, there are so many lesions there on the abdominal side. You can see some hepatomegaly, dilated portal vein with normal flow. That is important because we need a follow-up in this patient. So thick wall gallbladder with biliary sludge, diffuse splenic infiltration was seen, which is obviously the lymphoma finding in this patient. So there was nephropathy. It is controversial to someone, but you have to go for that. Okay, so there was diffuse abdominal lymphadenopathy. We tried to describe the areas, and yeah, some mild ascites with omental thickening, and there was a reducible umbilical hernia. So if you go for the neck region, there it is easy to say the multinodular goiter, but yeah, this one, the left lobe one, was the notorious thing. And we can see some large nodule on the a large nodule on the right lobe, which was showing the arteriovenous fistula formation. And some lymph nodes were showing the cystic appearance, and some showed the lymphoma appearance. So be careful. If you take sample from only a single lymph node, you will miss the diagnosis. So you have to compare many different findings. So before doing the biopsy, you have to understand, or you have to think about the actual lesion and from where you want to take the sample. If you take sample only from this large mass, large nodule, it may come benign because you are not taking sample from obviously the actual malignant area. So it's a large one, you know. So you have to take sample from this one, and obviously from the solid one on the left side. Otherwise, you won't actually see the papillary cell carcinoma. Okay, so yeah, but there is a lymphoma also. Okay, so this is the inguinal region. So there was bilateral indirect inguinal hernias, and there was a grade 4 varicocele on both sides. The testes were small, which might be associated with the age. And yeah, there was a right-sided mild hydrocele. Oh, so it was a big case, huh? So it took a long time to end this session. I'm sorry because the network disturbed a little bit because this is a toxic case, so network became toxic also. So this time I'll show you of case number 4, which is a very small one, and then I'll jump into another big case. So this is a 26-year-old female patient who came with lower abdominal pain and dysmenorrhea. Let's see what we have got on ultrasound. Okay, so you can easily diagnose this one, I think. So you can see the right ovary here, and the right ovary is showing a cystic area with internal variable contents. Like you can see some hypoechoic area, which is the feature of endometrioma, but you can see some anechoic portion also. And you can see some reticulation here. So this reticular pattern is the feature of hemorrhagic cyst. So for this case, we want to go for a hemorrhagic cyst. Okay, is it confirmed that this is one is hemorrhagic cyst? No. As I'm looking at some hazy area here, whenever you see endometrioma with active bleeding just after the area of just after the menstruation or on the 4th, 5th, 6th days of menstruation, you may see this type of situation. So always, whenever you make confusion between endometrioma and hemorrhagic cyst, do a follow-up. Just do a follow-up after 6 weeks. You will see the hemorrhagic content is absent, and you'll see the typical endometrium at that time. Okay, so this is an adnexal cyst, and on color Doppler, you can see there is no apparent increased vascularity. These are the ovarian normal vessels. So yeah, we want to go for it as an adnexal cyst. It's ovarian cyst, not an adnexal actually, because we can see the ovarian tissue over here. So we want to go for the URETS 2 score for this patient, and there was no color Doppler flow, so we will go for the color score of 1. Whenever you see the typical cyst like endometrioma, or chocolate cyst, or hemorrhagic cyst, or dermoid cyst, or corpus luteal cyst of more than 3 cent of any size, more than 3 centimeter usually we see them, and less than 10 centimeter, we go for the URETS score of 2. And if it's not showing any vascularity, we go for the color score of 1. Okay, so let's look at the left adnexa. So this is the left adnexa. Now we can't see the ovary separately, and you can see a very large sized mass over here, cystic lesion, not mass, because we can see the posterior acoustic enhancement over here. And now you can see internal low level echoes. So we have started a case of hematometra today with this appearance. So this is definitely the menstrual blood collection, which is nothing but a chocolate cyst or endometrioma. So the left adnexa is showing endometrioma, the right one is showing hemorrhagic cyst. That's okay, but you have to be careful and you have to go for a follow-up to ensure that you are not looking at a right adnexal endometrioma showing active bleeding forming or acute bleeding forming the hemorrhagic cyst-like appearance. Yeah, definitely that is hemorrhagic cyst for right now, but we need a follow-up, obviously. Okay, so this is the endometrioma. So this is the left one, and in normal appearance, you won't see the you'll see the anechoic appearance usually. So always try to use different settings of your machine. Try to use different transducers. You will be able to see the low-level internal echoes quite well. So this is the left adnexal one. So this is also less than 10 centimeters. So we want to go for the URETS 2. So we saw a right ovarian hemorrhagic cyst and the left adnexal endometrioma. We're not happy with the hemorrhagic one. And yeah, we want to go for a follow-up in this patient. So there's a URETS 2 and color score of 1. Okay, so let's case of the day, and obviously it will be a pregnancy case. So I have collected multiple pregnancy cases for you. Due to the time, it will take long to share all with you people. So anyway, let's start with the interesting one. I think this case is a fresh case, not very long ago. It's the case from not this Thursday, the Thursday before this week. So let's see what we have got on ultrasound. This patient is a 25-year-old female patient who had a history of amenorrhea for 4+ months. So let's see what we have got on ultrasound. So on first scan, we can see we have found two fetuses. So we just scored them as 1 and 2. The right one is 1 and the left one is fetus 2. So this is a twin pregnancy. We found 2 placentas. Both are actually, I think, posterior. I forgot. So this was a dichorionic diamniotic twin pregnancies. Both are live. Okay, let's measure the pregnancy. It's around, oh, the measurements are not satisfactory. You see, the biparietal diameter and femoral length are saying that it's around 18 weeks of gestation. Head circumference is also saying it's 18 weeks, but abdomen is saying that it's 20 weeks of gestation. So the abdomen is like my abdomen. It's just a bulged abdomen. Okay, so we have to look for that. So we took the measurements from the second baby, and it's showing around 18 weeks of gestation, and all the measurements are quite similar. So we are happy with this baby. Okay, this is the fetus 2, the left one, and it was completely normal. There was no abnormality. We searched from the head to toe and there was no abnormalities. So we are happy with this baby, but we are not happy with the first one. So let's see the first one, what's happening there. So this one is the first one. We saw the AC abdomen circumference is quite bigger. You can see some cystic spaces here. What have you just saw? So the patient was sent to me because the ultrasound expert who did the ultrasound of this patient the last night, she saw something abnormal here in the cystic space. So she sent for further evaluation, so referred the case, and I was very happy to see this case. I'm very sad for the patient, but I was looking for this case for a long time. So I was very happy to see it on my hand. Okay, so what's going on here? So here you can see a large cystic area within the lower abdomen pushing all the abdominal contents upwards. So whenever you see this type of cystic lesion, this is the typical appearance of megacystis, that is the enlarged urinary bladder. If it is enlarged urinary bladder, there should be hydroureter, there should be hydronephrosis. And what you want to see in this patient, you want to search for the orifice at the lower part, that is the posterior urethral valve. So you want to see exclude posterior urethral valve in such case. So let's look at the surrounding area. You can see the cross section, you can see some dilatation over there, but we have found our main finding. Let's freeze the image. Go a little backward. Go a little backward. Now you can see this bulging over here. This is the posterior urethral. This is due to the posterior urethral valve, and this is called the keyhole appearance. I'll show you a better picture, obviously. So this is a big abdomen with a large urinary bladder, showing the feature of posterior urethral valve. And now we want to see all other findings in this patient. So here's the transverse section. Now you can see the, just let me show you a little. You see this is the stomach and liver. Just go a little bit downwards. Now you can see the kidneys over here. They're showing hydronephrosis, the urinary tract dilatation, the pelvis is dilated. Now just go a little downward and you can see the whole urinary bladder is pushing upwards. So this is the typical keyhole appearance in this patient. So this is the typical feature of posterior urethral valve. So, okay, now the problem is that the patient is at the age of 18 weeks. So if you want to manage this patient, you can put a shunt over here, and the amniotic and bladder shunt, uh, through puncturing the urinary bladder. You can get that video and procedure in Google. So that may give a relief of this pressure. Otherwise, you will just destroy the kidneys, and if the bladder gets ruptured, you will see the whole ascites in this patient. So on follow-up, you have to be careful. If you see the bladder is in normal size and the patient is having ascites, you have to understand that bladder has got ruptured. Okay, so yeah, this is the posterior urethral valve in patient, and you can see this. No, this is not kidney. These are the ureters. Okay, so these are the distal ureters, some tortuous tubular structures. These are the dilated ureters on both sides. These are the kidneys. Now you see, this is the kidney, and these are the ureters. So let me freeze the image a little bit. The kidneys are not normal. Actually, you see the echogenicity. It's completely echogenic. I will show you the other one, the left one also. So this is not very good one. The patient is on breech presentation, I think. So anyway, so this is quite echogenic kidney. This is due to the, sorry, this is due to the obstructive nephropathy, or, or obstructive uropathy, whatever you say, due to the posterior urethral valve. So here's the picture of the kidneys. You can see they're grossly dilated and the parenchyma is getting thin and echogenic. Not a good case. Okay, so this is the urinary bladder, which is grossly distended, and you can see these are the ureters, which are bilaterally dilated up to the lower part, obviously. So you can see hugely dilated urinary bladder, and the ureters and the kidneys all are distended due to this whole pressure. Do you know what is the normal diameter of urinary bladder in a patient? So we'll show you. So this is the urinary bladder, and this is, you can see the keyhole appearance of the posterior urethral valve. Okay, so this is the diameter, and this is the length of the urinary bladder. You have to measure the largest diameter, and it is around 5.2 centimeter. The normal diameter depends on the trimester. In first trimester, it is if it is more than 7. In second trimester, if it is more than 30 millimeter, and in third trimester, if it is more than 60 millimeter, we go for the distended or dilated urinary bladder, which is called megacystis. Okay, so 7, 30, 60. That is the measurement. You can measure the highest length. That will be okay. However you measure, it should not cross this value actually. That is the easiest one. Okay, so this is actually the picture of the suffered baby. That is the fetus one. So this is the, yeah, this is the case. So this was a 17 to 18 years, 18 weeks of almost same size dichronic diamniotic twin life intrauterine pregnancy with, yeah, no definite fetal anomaly for the second one, and the fetus one showed the posterior urethral valve causing the megacystis and bilateral hydroureteral nephrosis with the obstructive renal dysplasia. So that's a complicated case, and that's all for today, obviously. So thank you for joining me. Our next session will be hopefully on 4th July. That is the next Friday. I'll try to be there for you, and yeah, we'll try to continue. If you're from my local country, we have a paid session tomorrow on lower limb venous Doppler. That is obviously a boring class if you don't love the Dopplers. If you're a foreigner, just don't get angry at my this type of paid sessions. We can't actually do this type of sessions for the foreigners, unfortunately, because these are in local language. And yeah, the payment system is not quite easy for the foreigners, and we don't have any refund option for the foreigners. If we can arrange refund options for the foreigners, then we can arrange everything for the foreigners. So that's why we're arranging free sessions for the foreigners on every Friday. We hope to do it in the future. Okay, so yeah, if you are new to our channel, or you want to repeat, or you want to see this records, you can just go to our our YouTube channel, that is Imaging Study, where we have got, fortunately, more than 480 videos and 66K plus subscribers. Thank you for that, obviously. Yeah, we don't we get some money from this YouTube channel, so don't forget to share it with your friends. But the amount of money that I earn in, I think, 2 months, uh, I just got the payment yesterday, so I can just compare that. The money I get from 2 months is usually what I earn in a single day. So that's why I don't actually do this thing for money, actually. Yeah, so it's for fun, and yeah, it's for sharing our cases and our stories with you. So that's all. So if you are from my country and you want to just join our any paid sessions, you can get the posts of or the description of those sessions on our website, imagingstudy.com. So thank you for joining me today, and I'm very sorry for the network issue and all the issues that you saw today. I had nothing to do because I'm using the highest speed in net right now, so and that's why I can't do more. So sorry for that. And yeah, if you have any question, you can just go to our Facebook Live and you can ask me there. Yeah, let me just check a little bit. We fortunately got many viewers today. Yeah, we can see many people from different parts of the world. Yeah, I can see one from Kathmandu, Nepal. I was there on, I think, April. Yeah. And I have friends in Bhutan also, so I can see them. Yeah, I have friends in all parts of Bangladesh, obviously. Wa alaikum assalam. Yeah, I can see many people from beautiful parts of uh, the whole Africa, and many Asian countries also. I can see no countries unknown right now. Yeah, I'm sorry for the net connection. I had nothing to do with that because it just happened suddenly, and yeah, I'm sorry for that, obviously. And it happened in the very important case today. I'll just let me check the comments actually. Yeah, the cystic lymph nodes that we saw on the case number 3 was due to the papillary cell carcinoma metastasis, but other lymph nodes are related to lymphoma. The patient is having two actually abnormalities there. The neoplasm is about the lymphoma, and yeah, the papillary cell carcinoma. Both are happening there, which is very notorious. And the patient has only one complaint: hernia. Because we are concerned about our scrotum, not about our brain or something abdomen. The testis is the most important part of the body. No, not the most important, the second most important. I won't tell about the first one. Yeah, okay. Just looking at the comments. Yeah, now I found a new country name here. I won't actually tell that, but yeah, I have found a new country name which I'm not aware of. Okay, okay, just looking at the views. Thank you. Thank you all for joining. If you find this video helpful, don't forget to share. That will be beneficial for us actually to reach more people. Renal lymphangiectasia is a rare case, you know. You see the multiseptate, always, if you see the lymphatic abnormality, you see the multiseptate cystic area. So when you see the multiseptate cystic areas surrounding the kidney is usually the feature of renal lymphangiectasia. It is usually unilateral and it's quite rare. So in my case, I think I have seen only 1 or 2 cases. So yeah, that's great. So thank you for joining me today, and hope to see you all on our next session. I hope it will be on the 4th July. So till then, thank you and be happy and be friendly to each other. So together we can actually build a very good world for our next generation. So thank you for joining me today. Hope to see you on the next one. Have a nice day.